congenital heart disease awareness week. You can get those, and those are just a few parents that now encouraged to come for the program. But as I said, more than 175 kids are on the list. They come every week for follow-up. There is no progress, no change. At least every week, one child who is dying of heart disease. So what we have a problem? Okay, so we look at this one as well. You say, I mean, look at that something like that before, and that one, we all know Civil War, about last everything that we did. And so we conducted the research. Okay, we see that when 2006, the head of the our 51, the services that we have to do that was population of 3.3 million. That was in 2006. After this, 2016, 60.51, that was we moved on to 219 that back with the actual inflation issue. And by 2021, the last time we did our research, we have 461 factors. We have reduced our inflation factor. That probably address. Everything is not lost. Everything is not collapsed. We have progressed. There is still hope. There is still hope, and there is still room for improvement. So if you look at the number of specialized, what we do that, we make the general practitioner at the end of the one medical school. We make general practitioner. So we look at only after you value the medical school specialized. You see there, okay, you have the general surgeon, then you do that OBGYN, that is higher, the fast specialized, and also this about the work. OBGYN is 34, we'll start coming down the line, pediatric, the canal medicine, the family medicine. We come back to the subspecialty. I'm going to see where we find that you survey. See, you survey here, we have 2%. We go down, we see that all of the subspecialty are far behind. We do have 2 years of allergy that the have 3 orthopedics that MONROVIA, that and that Lucy. We have 1 urology that I said, 1 cardiac surgery. The rest, one anesthesia is that no one, the rest we have. So we are still beyond those specialty medicine. These are the most critical people. These are specialists that need to be good and first transition. For 2 years, and basically one step above. But the complex case will be the subspecialty people we lack them. Our research, we said our rate of is 8 water acid like that. So they are limited standard diagnosis. They are no standard diagnosis 2. They are no patients. No patients are diagnosed by history and signs and symptoms. Okay, we lack the basic echocardiography. You recently I learned that you get a word for you got to be adult echocardiography for plants for children. Okay, and we see that children with other disease that they have no place to absorb it. They have that disease. You see, as for the not ask children when they will have disease that way. We see 50% of people die if they do something. So I put it down for us, the public children will die. They do something with God. And then our population growth rate of about 22.1%. You see, additionally, every year we have 200 children. We will have this adult with this already existing, but we don't ask if whether we have. Okay, in the next 10 years, we have 3,000 adults. So for each year we do, we have our center, we have moved up. And we see that, okay, we discuss this in this is the research program that you see here. Okay, we have at that time we were 476 children we saw. These are the subgroup development for heart disease we have in here. That's why it's a big development of family, big development of heart disease, that ratio of the period of death of cardiac disease that we have to see first. So we said that at respiratory foundation we have a proposal. Okay. The center is expected to be established in here. Our homework, our everything is done. I think people the system they start has already the lawyer part, I don't the lawyer part. I think the thing that as the general information, I will not by your government. I think I said the government took a scholarship from me a week before I did because it's our 50,000 then our complaining them that we were not doing well. And for sure they're not doing well. People are dying for people. Some of us feel that something did not close our mouth, we have to speak it out. The money is there. People are getting rich one the people in poor. When we speak these things, we got every of the government. So just a week for me to leave, I was and I'm not. Because I feel a long way. Okay? So I saw all the people I have and I do by the grace of God like that. I won't set this school. People must be 10,000 and if you say you want to keep on your own with formation, will allow you to continue to have the money. But one thing people realize is that I was a street star and an author. I was 8 years old when the parents of people asked for my impact. I spent 5 years in the street, and then God that took me from the street. He cannot leave me alone. No one will take it from me. So that was that I will not stop, but we will make sure that these children and the others population and we are trusting God that 2026 will be the first movie and it's not important for everyone. And our budget for is just the first $1,000 that I'm asking for the past 2 years give us 150,000. You do not have to pay at work. You can share it. I mean, every budget quarter is 50,000. Like for example, January budget is 50,000. We set this start for training. That is the next 50,000. You pay at least fees again. The house will be the problems. Next year, give another 50,000. Are you saying that one budget is too much for the government to give over 2 years to bring into the system? But that is not the government answer. I was at the one. We make a system in our Africans, not in this family, we want is right. So this is the bypass station that we take the patient, take what the portion of the patient have. By the grace of God, so many according to that you have to train that around this. So you can give the body that we go. This is the ethical value patient that we need. That does the both of the happens that we will be able to and $50,000. I'm sure you have to start with something and people you can also get that thing. The issue of a product story that people want to invest, but they will not pay any construction. You have to treat your staff, get a place set up, and you will come with equipment, and then continue to help you. So that is what we want to do. Okay, and this I got a shot for me to show you there. I'm not sure that will share with I'm going to share that with you. For our presentation. That is very hard. But the hope is not there. Hope for me, there is no death. While there is a God, there is a for me. I don't know your faith. But my faith in that is beyond anything in life. Because God has never disappointed. He did it for me personally. I'm not sure we will do this, but I'm asking him for a group of vulnerable people. He will say no. I'll show you brothers from the street for a purpose, not to just be a doctor, but to be a doctor with different results. That's how he brought it to the life. So what do you find yourself? Why are you positioning with you? Why you think it is? God is ability. With God with you. I would like to give you a scenario of this. And I'm not going to visit to GFA. I saw this place. The people, one of the regular ones that visit. Probably place to see what the children who have disease. According to this guy, very big and we were having problem. This documentary was taking a permission of the family to use it for awareness and fundraising. So the family did about the issue, share them. That is why we are not black in them. We want people and we want to see the real pictures from our history. Okay. So if you go down, further down, you see, okay, this is the spot out of the where people at the level. You see that chair, you have a short interview of God. And then these were the parents that came for that day, they came for that follow-up. This is regular follow-up. This is some of them, I mean, we didn't have the newspaper by the medication. There is one particular case I want to show you. As a child that looked at the condition of 6
Yes. Rehab. Yes. Pero, adorant, would like to and please no issue. Deputies, and how let's give you a more time. Next year,
Afternoon. Anybody can hear me? Anybody hear me?
Yes, Dad. That is super. We can hear you. Just want to connect you to the bigger microphone.
Oh, okay, good. Thank you. Will you project my screen or will I be the one projecting my
Yes, I'll
presentation?
present.
Okay, thank you.
But you joining from um, um if you want to share, you can also share by yourself. By right.
Yeah, but you have to make me the host to be able to share my screen.
Okay. Yeah, I will share it.
Okay.
If you get there, exit even anything, book your knowledge, there will be very fast. The movie of blood vessels, the blood vessel. This is the past where they just not this is a patient pressure. You have to do the free food. That's the way the system. You have to focus at the peak, at the peak of
Hi, I'm over to Dr. Dede Ashi. Hello, are you there?
Yes, I am. Yes, I am. Good afternoon. Good afternoon. Can you hear me? Hello? Hello? Yes, can you hear me?
Yes, can you hear me? Yes, can you hear me?
So there are a lot of people need
Yes,
to
can you hear me?
a lot of people need
Yes, can you hear me?
Okay, I'm hearing someone asking if I can hear them, but I don't know if that question is directed towards me. Dr. Bala, are you there? Could you please project my
Yes, I'm
presentation?
here. We can hear you loud and clear.
Yes, I'm here. We can hear you loud and clear.
Okay. Good afternoon. Thank you for inviting me once more. My name is Dr. Teresupu, and I am a medical oncologist, meaning I am a cancer doctor. I was asked to talk today briefly about breast cancer, which is one of the commonest cancers that we have been diagnosing in Liberian women. So for the next 10 minutes, I will quickly take you through some basic information that you will need to know about cancer, breast cancer to be specific. Um, okay, so yes, so could we please just skip to the next slide, please? Please go to the next slide, or you could just make me a host so that I don't have to bother you about when to skip and when not to skip. So when we talk about cancer, we are basically referring to um, cells that are growing out of control in the body. And when we are talking about breast cancer, we are talking about cancer that's happening within the breast. Um, it has to do with abnormal control of abnormal and uncontrolled growth of cells in the body, and it happens wherever in the body. So if it happens in the breast, it's referred to as breast cancer. Um, next next slide, please. Dr. Bala, could you just make me the host so that I don't have to keep saying next slide? So, worldwide, breast cancer used to be the most common cancer diagnosed amongst women. However, according to the most recent data that we have available, breast cancer is the second most common cancer diagnosed worldwide. The most common cancer diagnosed worldwide is just hold on 1 second. Let me share my screen. So the most common cancer diagnosed worldwide now is lung cancer, and breast happens to be the second most common cancer. So in Liberia, according to WHO, about 3,555 cases of breast cancer of cancer were diagnosed in Liberia in 2018, and breast cancer accounted for 528, which made it the second most common cancer diagnosed among women. The most common cancer diagnosed among Liberian women is cervical cancer. So also in 2018, we had 2,223 deaths occurring from cancers amongst Liberian women. And out of the 528 breast cancers that were diagnosed, 300 of them died, which accounted for 11% of the total number of cancer deaths. And this made breast cancer the third most common cause of cancer-related death among Liberian women. In Liberia and other underdeveloped countries, the cases are relatively low due to lack of honor reporting. We don't have a good reporting system, so it is expected that this number will increase significantly as time goes by. So what are those things that increase the risk of us developing breast cancer? There are several factors that have been documented that are directly associated with the risk of developing breast cancer. And most women who present with cancer, interestingly, do not have these risk factors. So the risk factors can be classified as modified risk factors and modifiable and non-modifiable risk factors. When we talk about risk factors, we are talking about things that when they are present, they increase the chances of you developing cancer. It doesn't necessarily mean that you will develop cancer when it's present. It simply means that with the presence of these factors, the chances of you developing cancer is higher compared to someone who isn't. So what are those ones that are modifiable? When we talk about the modifiable risk factors, we talk about things that we can control, that we have control over, that when we adjust our lifestyle, it reduces our risks. So they include observing our weight. If you are overweight or you are obese, it increases the risk of you developing breast cancer. Another thing is lack of physical activity. You sit all day, you don't exercise, you don't get up, you hardly move about, you sit at the office desk from 8 a.m. to 8 a.m. to 4 p.m. You get up for barely 5 minutes. That's a risk factor for breast cancer. Taking oral contraceptive pills, what we refer to as family planning tablets, those are all associated with increased risk of developing breast cancer. And then for the reproductive history, so the alcohol intake and smoking, those are all risk factors. Those are things that we can adjust and reduce our risks. But with these present, if you drink alcohol, your risk of breast cancer increases. So for the ones that we cannot do anything about, the first thing is that um being an elderly female is risk factor all by itself for developing breast cancer, and there's nothing you can do about it. You cannot change the fact that you are old, and you cannot change the fact that you are a female. So being an elderly female is an increased risk factor in for developing breast cancer. The next thing is there are certain genetic mutations in our bodies. We call them the BRCA1 and the BRCA2. So if these mutations are present, and when we talk about mutations, we are talking about abnormalities in the body that are affecting our genes, because we know that the genes make us who we are. So there are certain genes in our bodies, when they have problem, they increase the risk of us developing breast cancer. I like to describe the genes as us having two legs. So you're supposed to have two legs to be able to function properly, but if you have one leg broken, then it becomes a problem. It's the same with the genes. If one of the leg is broken, it's an increased risk of developing breast cancer. And then for some other reason, another leg gets broken, it just increases the risk of breast cancer even more. So then we move on to the reproductive history. What do we mean by that? How early you see your period, your menses for the first time. If you see your period for the first time before the age of 12 and you went into menopause after the age of 55, that is an increased risk for developing breast cancer. The other thing is, if you have never gotten pregnant before at all in your life, it's an increased risk for developing breast cancer. If your first full-term pregnancy you had was after the age of 30 years, that is also an increased risk for developing breast cancer. And these are things that you can't do anything about, because you can't tell yourself when you will get pregnant or when you won't get pregnant. The other thing is family history of breast cancer or ovarian cancer. It also increases the risk of developing breast cancer. Like, for example, if you have a family member like your mother, your sister, your daughter, or if you have an aunt from your paternal end, I mean, even if it's your maternal sister, if there's a direct bloodline between them, and any of these people have breast cancer or ovarian cancer, the chances of you developing breast cancer is increased as well, because these cancers are associated with the genetic mutation that I mentioned a few minutes ago, the BRCA1 and the BRCA2 genes. And then previous history of another form of cancer treatment that is called radiation. So if you had any cancer before that was located within your chest and you had to receive radiation for it as a form of treatment, that increases your risk of developing breast cancer at a later date. So how does breast cancer present? What are the signs and symptoms of breast cancer? So first thing first, what we need to understand is that most times cancers are asymptomatic from the initial stage. But for breast cancer, the most common symptom for breast cancer is having a new lump in the breast or under the armpit that is different from the rest of your breast tissues. So as women, every day, every month, we're supposed to check our breasts. And if you notice a new lump in your breast that was not there before, this should raise an alarm and should alert you that you need to go and get yourself checked. If there's a change in the size or the appearance of a breast, so if your breast was, for example, you had a breast that was the size of a grapefruit, and then now it's the size of a basketball, that should increase, that should tell you that something is not right and you need to go and get checked. So if there are changes, another symptom of breast cancer is if there are changes to the skin, like dimpling. It usually looks like, if you know how the orange looks like when before you peel the orange peeling, before you peel off the orange, they usually has hole in them. So the way the orange peeling looks is how the skin usually looks. So, and is in fair skinned people, it looks red and inflamed. In dark skinned people, the skin appears darker than the rest of the other of the other skin. So if you notice any changes of skin changes on your breast, then that should raise an alarm for you to go and get checked. A newly inverted nipple, what does this mean? Breast nipples are supposed to be directed outwards. But if something is pulling it from within and you notice that your nipples are looking like they've been drawn in, that should alert you that something is wrong and you need to get checked. Peeling, scaling, crusting flakes, or itching of the nipples or the breast skin, those are all symptoms of breast cancer. Um, and then sometimes the lump will be painless. Most times the lump will be painless, but sometimes the lump might get painless. And when the lump gets painless, that is also a risk factor for a sign of breast cancer. Last but not the least, if you have a nipple discharge, if you are not a breastfeeding mother, your breast is not supposed to be producing any form of discharge, whether it's milk or not. So if you have nipple discharge that is whether milky or bloody and you are not a breastfeeding mother, that should raise your concern that, hey, I need to get checked. There's something going on. So this slide is just going over all those things that I talk about, changes in the look and feel of the breast, where we talk about redness, we talk about lump in the breast, we talk about swelling, lump in the armpit, because one of the first places that breast cancer spreads is underneath the arm because of the way in which the blood and the fluids from the breast are drained. The next thing is the orange peel texture, the dimpling and discharges and what have you. So these are just pictures of what they look like when you are talking about breast cancer. So again, this is a picture of orange, of various oranges, and they try to depict them. So here we see two different lumps. Here we see that instead of the orange stalk being out, is being pulled in. So this is an example of what nipple retraction looks like. As we can see here, the orange peeling here looks red. And if you look closely, you will see that all these orange peelings have the dimpling. So this one looks red. So this is what we describe when we said the skin could be red-ish looking in unfair color people. This one here describes the dimpling that happens on the skin of the breast when there's breast cancer. So how can I reduce? Now we move on to how to reduce the risk of developing breast cancer. The first thing we need to do is to have a healthy weight. We need to keep our weight healthy. I know in Africa, our African men like meat. They say, oh, the bigger the better, but it's better that you keep your weight within a healthy range, because being overweight is not healthy for you. It's not only increasing your risk of developing breast cancer, it also increases your risk of developing other cardiovascular problems and what have you. The cardiothoracic surgeon is there, and I think he can speak more on that. So exercising regularly is another way to reduce breast cancer, because when you exercise regularly, it helps to keep your weight in check, and then this also reduces the risk of you developing breast cancer. Also, you have to avoid drinking alcohol or limit how much alcohol you take in. On the average, on overall, avoid drinking alcohol, because drinking alcohol does not only increase your risk of developing breast cancer, there are several other types of cancers that are associated with it. If you are a female that is experiencing menopause and you are taking what we call hormone replacement therapy, you have to stop, because it increases the risk of developing breast cancer as well. If you are taking family planning tablets, I am talking specifically about the tablets. If you are taking the family planning tablets, you have to stop because it increases your rate of developing breast cancer. There are other methods that you can use to prevent unwanted pregnancy. There's the implant, there's the injection, and you can also use barrier method, which is condoms if you must have sex. So if you are using family planning tablets, please stop because it increases your risk of developing breast cancer. And then when you have the children, breastfeeding is protective. Breastfeeding children is protective. I don't know about men sucking, grown men breast sucking on a female's breast because I get asked that question a lot. So I just want to make it clear that the breastfeeding that I know science is talking about is breastfeeding children, not grown men. Grown men are not supposed to be sucking breast milk. So please take note. If you have a family history of breast cancer, or if for any reason you think you may have inherited breast cancer genes, it's good to talk to your doctor and get checked. In other countries, there are ways in which you can check for these genes, and if present, you can, and you are no longer, you don't desire having any more children, you can either have your breast and ovaries removed. It's called prophylactic mastectomy when you remove the breast, and prophylactic ovarectomy when you remove the ovaries, because the BRCA gene is associated with the both breast and ovarian cancer. It's also associated with pancreatic cancer as well. So if you have a family history of pancreatic cancer that is associated with this BRCA gene, even if no one else in your family had breast cancer before, the fact that there's a history of uh, pancreatic and prostate cancer, they also link with these genes, so there's always that increased risk. So in other countries, like I said, they do test for these genes, and if the person can opt to have the breast removed and to have the ovaries removed. We don't do that in Liberia, so if you want to do that, you have to find a way of getting out of the country to get tested. So what's the importance of screening early diagnosis? Although prevention helps to reduce the recurrence of breast cancer, some of them still occur. So that is the reason why we have to do early screening and diagnosis. Because when we do screening, it helps us to catch cancer cases at a very early stage where something can be done for it. In some developing countries, there have been several screening programs that have been put in place that help with the early diagnosis of breast cancer. And there are several methods that they use. The most common ones include the mammogram, which is the X-ray of the breast. Then you have self-breast examination. That can be done at home by the individual. You can do that at home, every month at the end of your menses, where you stand from the mirror, put your hands on your hips, look from side to side, look at your breast, and put your hand on your head, feel on your arm, feel around your breast softly using inside the palm of your hands right here to do your examination. So then also you have to do your clinical breast examination. That has to do with going to the hospital yearly to your doctor so that he or she can examine your breast. Now, what is a mammogram and when is it done or when should it be done? A mammogram is simply an X-ray of the breast, and it is used to detect early breast cancer cases. Sometimes the mammogram, because it's looking at the level that we cannot see with our naked eye, sometimes the mammogram will detect a breast cancer probably 2 to 3 years, even before the patient starts to show signs and symptoms. And it is advisable that at the age of 40, women should do the breast cancer screening early. So at the age of 40, starting from 40 years, please try to go and get your annual mammograms done. We do the mammograms in Liberia now. It's done
Hello
at
there.
Jamali. If there's no, yes.
Yeah, please hold on a minute. There's a problem with the network, so they are not hearing you.
Okay,
Just a minute.
okay, so where did I stop? Where did they stop hearing me?
I am getting you, but they're not getting you with. Okay, so it's the same place, right? You can be there. I think they are trying to set it up. after setting it up, and then I will let you know. They are still fighting on. The network is kind of terrible.
Okay.
So screening. I'm Pastor Andrew. So just hold on a minute, please.
Hello there.
Yes.
That's cool.
Yes, Doc. Can you hear me? I'm here.
Yeah, so the speaker went off a few minutes ago when I hearing you. So can you speak again? Let's see what I can hear you.
Hello. Hi. Good afternoon.
The microphone. Yes, you can hear me?
I can hear you loud and clear.
You can hear me?
I can hear you, Dr. Bala.
Okay, so it's a microphone. Okay. Yeah.
Everything okay now?
Hello, Dad. Are you there?
Yes. Yes, I'm here.
Okay. Just hold on a minute. Think they are trying to connect.
Yes.
Okay. Try. Let's see.
Hello. Can you hear me?
You can talk. Let's hear you, Dad.
Yeah, can you hear me now? Am I loud? Am I being heard?
I'm hearing you, but it's not going through the speakers. Yeah.
Recording stopped.
Now let's see. Now suppose you can speak now.
Yeah, can you hear me? Hello?
Yes, you can go ahead.
Okay, so I don't know where I stopped, or where the mic went off, so I will just go back to the screening and early diagnosis of breast cancer and why is it important. Um, it's very important for us to screen and diagnose early for breast cancer because we will be able, that's the only way we can catch the disease early enough to be able to correct it before it causes a lot of damage. So, however, in Liberia, other underdeveloped countries, screening and diagnosis have been a problem. But in countries where they have a lot of programs in place to screen and diagnose breast cancer and carry out early diagnosis, there are three major ways that they conduct it. Number one is the mammogram, which is the X-ray of the breast. To self-breast examination, and clinical breast examination, which is going to see a doctor every year to get examined and tested for breast cancer. So what is a mammogram? A mammogram is an X-ray of the breast. It usually detects the breast cancer very early, even before we, the health workers, can detect it, even before the individual herself can detect the breast cancer. So sometimes mammogram can catch a breast cancer as early as 2 to 3 years before it becomes symptomatic. And then it is advised that starting from the age of 40 and above, a woman, every female should do the mammogram every year in order to be able to catch the cancer early if they do develop breast cancer. So the self-breast examination, women are advised to do self-breast examination every month at the end of a period. And it's very simple. Look at your breast, standing from the mirror, look at your breast, feel your breast, put your hands on your hips, look from side to side, and look for just anything that's abnormal. Look at the skin of your breast. Is it okay? Is it the same as the both breasts? Are they the same sizes? Are your nipples pointing out, or are they looking at something holding it inside? You feel around your breast. You use the inside of your palm of your hand, your finger here, and just feel around your breast quickly, with your hand up on your head, and feel underneath your arm as well, because like I said, one of the first places that breast cancer spreads is underneath the arm. You can do that standing, or you can also lay down on your back and examine your breast. That is the self-breast examination. So they said that you should visit a doctor every year for a full examination, including clinical examination of the breast. This will help you detect breast cancer early, and that is the only way we can do something about it. So what is the take-home message? The take-home message is that breast cancer is the second most common cancer diagnosed worldwide, and it's the second most common cancer diagnosed amongst Liberian women. There are several things that will increase your risk of developing breast cancer. Some can be modified, others cannot be modified. Most importantly, what we need to note is that being a woman and getting old are the most important risk factors for developing breast cancer. So what do we do? Take care of your health by eating healthy, by exercising regularly, and reduce or stop your alcohol intake. Observe your breast. Anything out of the normal should lead to a doctor's visit. Always remember to do your monthly breast examination at the end of your period. get your mammograms done every year starting from the age of 40. Last but not the least, educate someone about breast cancer. Because if each one teaches one, that is how we fight cancer. That is how we reduce the mortality rate of breast cancer in Liberia. Thank you for listening. Once again, my name is Dr. Superwood, and I will stop here for now and pause if there are any questions to be asked. Thank you. Thank you for listening. Any questions? Dr. Bala, are you there? So I'm not hearing anyone. Everyone is muted. I'm assuming that there are no questions. So I think at this point I will turn the program back over to Dr. Bala, who will take over from here. And I will log off now if that's okay with you all. Thank you for the time. Thank you for joining me today.
I'm coming. Hello,
Yeah,
Dad.
that is super.
You getting me now?
Yeah, there are
Yes,
questions
Mm.
we're echoing. There are questions.
okay.
Okay, the first person is here with a question.
Hello.
Yes, sir.
Okay. I am Mary Chawara, physician assistant. Concern has to do with the risk, the risk factor of breast cancer we're talking about. We know that today our young people are encouraged to take the family planning and they are taking it. So what will become ovarian and also the womb in the long run, because we know that the ovarian and the womb also develops cancer. What will become of them?
So are you asking what happens to the womb and the ovaries of a female who stops taking birth control pills?
I say because you said the risk factor of cancer, breast cancer is one is the family planning. And
Yes.
now the family planning is encouraged by our young people. They are taking it to prevent, to control, and to space pregnancies. So what will become of them in the long run as they taking it? What will become of the womb and also the ovarian? Because I know that the ovarian and also the womb develops cancer.
Yeah, so the family planning tablets increases the rate of developing breast cancer. So if you continue to take the family planning tablets, your risks or the chances of you developing breast cancer is increased. So it is advised that you avoid the
All right.
tablets. However, there are other methods that you can use for your prevention of unwanted pregnancies. You can use the depot, you can use the implants, and there's also the barrier method, which is the condom.
Mhm.
Was not clear enough. For the presentation, does breast cancer also occurs in men? If yes, what are the factors? Yes, breast cancer can also occur in men, even though it's very rare, but breast cancer can occur in men as well because it is, like I said, it is linked to the genetic mutation, the BRCA gene, and that BRCA gene is associated with prostate cancer, pancreatic cancer, breast cancer, and ovarian cancer. So if a breast cancer happens in men, I have seen, while I was away studying, I saw about 3 cases of breast cancer in men. And they present with the same lump in the breast or knots in the breast as we will see in lab, or again, knots in my titty. So the men can also have knots in their titty as well. And sometimes they might even have a nipple discharge. But the most common symptom of breast cancer in a male is women undergo surgeries. Next question.
Yes, hold on, somebody's coming. Stand right there.
You as a person or doctor, for family planning was this breast cancer. And nowadays you have people that are producing these subjects going on air for school, high school, university, and all around. Like letting people about the benefits of these things. But they don't tell them the negative part. Or they say that this benefit is taken as so happy to you. So what is being put in place to eliminate these subjects? Because this conference, not everyone will have the opportunity to get it. Not everyone will have the opportunity to do research on their own. And some people are illiterate and they only take advice from what they hear. People go to them wearing them and they reject them. So what is important is to eliminate this form of cancer?
Yeah, thank you. That's a great question. What we need to do is, can you hear me?
Yes, we can
Yeah,
hear
yeah,
you.
go.
Okay, yes, I was saying, thank you. That's a great question. What we need to do as health workers and as stakeholders in the health sector is that we need to create more awareness. Um, Even the Bible says, because of knowledge, lack of knowledge, my people perish. So, ignorance leads to can lead to death. So we, the health workers, what we need to do is we need to educate the public more about breast cancer. And when we are giving these messages out, because cancer issue is a holistic thing, we need to work along with each other. So the Ministry of Health needs to call in several people, including the Family Planning Division, Family Health Division, whatever. So we need to work together to come up with a message that will be clear and that will resonate with the public, the general public, that they will understand. But we need to make them understand that taking the family planning tablets increases the risk of breast cancer. There are several other ways in which you can prevent family planning, like I've mentioned repeatedly, the depot, the implant, and even the barrier method. So there are other ways in which you can prevent unwanted pregnancy. Interestingly, we tell our young children, our young daughters, and our young sisters about the family planning tablets, about avoiding unwanted pregnancy. What we do not tell them is that, and they take these things and forget that um even though it's preventing pregnancy, but it does not prevent unwanted, it does not prevent other sexually transmitted infections. So people just go about, taking these tablets and forgetting about themselves. However, the barrier method, because I mean, when someone wants to have sex, you can stop them. So I would advise people to use the barrier method, use condom, because that way you will also be preventing sexually transmitted diseases and infections. So what we need to do is we need to create more awareness. Thank you.
That's all.
Okay, so thank you so much for the.
Thank you. Thank you for having me here today. I'm sorry that due to conflicting schedule, I couldn't be with you in person, but I hope next time I will join. But thank you for your time, and I think I can log off now. Dr. Bala, thank you for inviting me again, and I hope to be a part again someday soon. Thank you. God bless. Bye.
There of Icmfel and also new project. And they going to be presenting on congenital this project together as we invite Dr.
All right, thank you, I'm the host of the last. Yes, last not least, and try my best, so it can be time, and it's the share my screen. So, thank you. Sleeping now after lunch. This is, the most difficult time when people are tired. Yeah, but also the six, we hope to, wake you up because, our presentation is about the practical aspect of the conference today. Today we've been doing a lot of talking and all the things we've been doing. Thank you to my, professional colleagues. Thank you, Dr. Supo. Thank you, Dr. Hunt. Dr. Supo is like URMA, who's working in medical oncology. So, like the doctor specialized in cancer, kidney medicine. We have other oncology in peace, in OBGYN, or medical oncology. So she's very busy, has a lot of patients to do as well. So thank you that you show up. Thank you, Dr. Hart. Dr. Hart is also, Nigeria only current only cardiothoracic surgeon in her challenges. So, I'm happy to be one of Nigeria neurosurgeon, at least two. I'm talking about congenital hydrocephalus and I say it's because after the conference, after tomorrow, we'll be treating some of these patients. We'll surgeon again. So, one of my patients, two of my patients will be here tomorrow. The ones that will operate there on JFK. But one of them that, really gets started and that even, brought about the entire project. The mom said, hey, that will be at the seminar, we'll get to the program. I like, no, tomorrow you should talk to the people. She said, no, I gotta bring here. So she's here, Tisha and your mom is here, so I just want them to come up. So we can see them for 2 minutes and before. Thank you. So Tisha, mother, Tisha, daily. So, she actually won a petition, that's the project, and we want to have to follow up. My daughter was being to his brother, now he is control of head, 15 is really well. So, yeah, so the public is part of the car, and so the first, we are so excited that last year, you know, about to have mine. So,
It's off?
You gotta be excited about it. So, now I'm just going to have the, 0.11 was very, and you have a top right for second, we have very few, that is 32 hours a day, and then, put it right. One, 100 minutes of photo of so thank you for So Fisher and Mom will be here tomorrow, hopefully to share the story. But yes, that's something to tell you what we're gonna be talking. It's not just theoretical, yes. What on earth? How are you looking for it? I see your operation with that. You know, people are what? That's not so popular. I think there are people who have consummated the operation. They growing up, they have their own children, they have grandchildren. We heard Dr. Jordan, somebody from Canada, who also was born with congenital hydrocephalus operation farm, and then everything cool. Of course, as in Canada, you can say it's developed well. And nobody knows in the church, school, and everything. When she shared picture and picture story, she couldn't be that. She and her family, they don't have much, but they couldn't be there to pay for almost 2 surgeries. So yes, the ladies can survive, they can have life. If the man or woman, they get married and have children, they have a whole life. Like I said, some of them could be president, next neurosurgeon, everything. So it's not just taking one baby. I look at Gina and go up around there after a few months to die. No, the truth is that we can really give them what it needs. These are people who will contribute to our society. So I will try to make the medical term less simple because I know not all of you interested in the medical thing, but this is a story. So congenital hydrocephalus. What is that? What is the meaning of that? What is the definition of congenital hydrocephalus? So it's what we call there's a normal accumulation of cerebrospinal fluid. That means water. So the brain has special water. So we say water around the brain is a special water that around the brain. So that water is called cerebrospinal fluid. So there is normal quantity that's supposed to be there. So every 8 hours, the brain produces like 50 ml. So in 24 hours, that's like 150 every day. So that quantity, that's after 8 hours, the 50 that is produced is reabsorbed, another 50 is produced. So like in 24 hours, you have the 150 produced normally, but it circulates. But if there is problem, we come to that later, that 150 that is produced in every 24 hours is not being circulated. Then you have a normal accumulation of that fluid within the ventricle of the brain, and that's what we call basically hydrocephalus. So the epidemiology I'm talking about, what is it like globally? So you have like 1 to 1.5%. Green light is not just 1.2 you have anywhere. The incident is like 0.9 to 1.8 per every 1,000. Statistic, but in Latin America, in Africa, it's quite high. It's highest in America. Latin America, you have 360 per 100,000 births. And in Africa, you have 145 to 100,000 births. So there is quite high in Latin America and Africa. In Liberia, they have not been data such and published paper about the statistic about the incident in Liberia. So I started to award basically at JFK from 2021 to 2023. How many of these patients have been seen at JFK? How many that got from possibly in terms of the incident? It's lower in the United States and Canada, but of course it's there in United States, 80 to 100,000 there. So, but yes, it's there, right? We have evidence this morning of the joint telling us from somebody who's already an adult. So, the higher incidence is low in middle income countries. Of course, high food birth rates, high prevalence of neglected tropical diseases. We don't very know that some of those diseases are risk factors. So etiology, that means the causes. What happens? Generally, there are two reasons we gave. There is what we call subnormal CSF reabsorption. Reabsorption means the CSF is produced, whether it's produced, it's supposed to be reabsorbed, right? It comes to go. So if there's a normal in that reabsorption, we require two kinds of hydrocephalus to be developed, either obstructive, what some people will call the non-communicating, and then the communicating, what we call the non-obstructive. That actually has to do with the issue of reabsorption. Also, there is overproduction that will be, instead of producing 115 24 hours to be producing 300 or more than that, there's abnormality in that. So that could cause here. Specific causes as well, which is congenital that I'm focusing on. So there are different kinds of hydrocephalus. We'll see that quickly later on. Some admitted, but specifically you have congenital. Congenital means something that happens at birth, right? During the whole development time, right? So it's congenital. Then you have acquired, that means after birth. So it's not at birth during the pregnancy, is something that happens after birth, you acquire. So we look at quickly the congenital ones, they have abnormality that could cause that. For example, we have medial malinosis. Medial malinosis is normally during development, the spinal cord, there are times where the spinal cord will develop, and then there are spaces in the back, at the child, those spaces close. If there is any abnormality where the baby may be born at the back, I mean, certain part of the spinal cord may be closed, that can also lead to the fluid, because the fluid, the cerebrospinal fluid around in the ventricle around the brain also comes from the spinal cord. So if they have any neurotube defect, like a spinal bifida with knocking the back, there's a defect that could also cause congenital hydrocephalus. So many of them, most of the babies born with knock on the back, where there is a defect in the spinal cord, they do develop hydrocephalus. There are some of them we operate on them, so it's a normal practice. When we see a baby with neurotube defect, we expect even after surgery we do the so we do, if they are still quite young, we do ultrasound, and sometimes we just do both the division and the repair of the spinal bifida, because it happens. And it's kind of more related with another abnormality called Chiari type 2. That one also comes in play a part in developing that. Then you have, this is for the medical student, and the other people don't get bothered with this word. Danny malformation can happen, X-linked inherited disease. So this X-linked, we're hearing the medical oncology, we're talking about genetic. So there are also genetic issues that because that. One of the more critical one I could make you understand, for example, very close genetic link marriages, what we call maybe first cousin or brother and sister. Yes, that genetic link cause that. So these are the congenital aspect. Acquired infection, so which is the most common cause of communicating hydrocephalus, especially the congenital one. So infection, whether during pregnancy, that because or even after the child is born, if the baby had infection that will affect the brain meningitis, it could lead to post-infection in the baby to cause called hydrocephalus. And then post-hemorrhagic. So babies are quite soft and the score is not really thick yet. So when we operate them, we don't need any drill. So like for the adults, I'm looking for me to buy drill to do surgery for the score. It's hard. For the baby, I guess it's net to poke the score and get in, right? So the score is very soft. So you see, baby mom are very careful how you hold their baby because if they fall on you, of course, it's very easy for them to bleed. So if a baby fall for you, or you hold the baby high on the bed and there is bleeding in the brain, yes, you need to hydrocephalus. Because even adults, if you have an accident, you have a bleeding around your brain, you could develop hydrocephalus. There's a post-hemorrhagic hydrocephalus. So yes, hemorrhage means bleeding, you can have it. So secondary to masses, if you have a brain tumor, in discussing obstruction, so people who have brain tumor they could develop hydrocephalus as well. Post-operative, people who have posterior fossa tumor. So if we will do operation, after operation, that's one of the risks, you could have hydrocephalus. So many times, either right after that brain tumor operation, before you shunt, that after the surgery, you could develop hydrocephalus. And we also have neurosacchardosis to cause that. Then we have what we call constitutional ventriculomegaly. Usually there are people who call it constitutional because there are people who call their head. The normal, you get big head, just because the ventricle is very large and everything. But the normal, they don't have any clinical presentation or any symptoms like somebody would say, no, my brother also drinking, but the normal, right? So there's some people who have very big hair in large ventricle, but the normal. But it's also hydrocephalus. So we also we have associated spinal tumor. So even we have tumor in the spine, we also call hydrocephalus. So these are the acquired ones after birth. So infection, post hemorrhages, or after surgery, pre-surgery, yes, that could happen. I was talking about the different ones. So apart from the congenital one, the ones having the babies, we also have other type of hydrocephalus, the normal pressure hydrocephalus. So most of the time, like in adults, you can have excess water around the brain, but because normal, everything, the pressure, it's not like you have to keep the pressure. But yes, it's also another special type of hydrocephalus. Then we have what we call intractable ventricles. Then we have what we call erected hydrocephalus. So like there's a baby, that child is like 7 years old. Another one like 5 years old at the girl. So actually for this reason, after evaluation, I told the mother, this is already arrested. Even before you son is not going to change anything. So after second time, it's not going to change. So you don't put your son. Except if the person starts to have seizure or have other complication. But there are times where the hydrocephalus can get arrested. So birthing like I was saying, there is no published paper that's not available, but I'm working on this. I came by 2023 as a neurosurgeon. I've been in neurosurgery and connected with Dr. Dole since 2019. So yes, I have an idea of some of the common diseases in neurosurgery and so, but Dr. Dole actually started doing surgery at JFK in 2020 and 2021. So 2019, 2020, we were more in Tapeta at the hospital. So we started doing OBDC, some patient at JFK 2019, before I left, and then 2020, and by 2021 started doing some other surgery. So I went back to see of all the pediatric patients, I mean the babies that went to see seek neurosurgical consultation in the OPD. So I was able to collect the statistics to see how many of them, the babies that went to the neurosurgery clinic, how many of them have hydrocephalus, and how many of them have been operated since 2021. So in 2021, there were like 21 cases, children pediatric cases in the OPD. Like I said, you just started seeing patients around that time. So, and out of the 21, 5 of the cases were congenital hydrocephalus. In all 5 operated. And then in 2022, we saw like 8 cases pediatric patients going to see only, neurosurgery, going to the neurosurgery clinic, the pediatric cases were 58. And out of that 58, 7 of the cases were actually congenital hydrocephalus. The others were different cases, neurosurgical concern. And about 6 of the cases didn't come through the neurosurgery consultation, but were referred from different hospitals around Liberia. And about 13 surgeries for congenital hydrocephalus was done in 2022. In 2023, we have like 64 cases of pediatric patients seen in the neurosurgical OPD. And out of that, 12 of the cases were congenital hydrocephalus, so they keep going up. And all of the tours were over in 2023. And so we should be part of that tour this year, because we operated from last year, November, December. So I'm still working on statistically to article, and so we can have more data about JFK. So that's the burning in Liberia. What are the risk factors? So central nervous system infection is a risk factor. So if you have infection that will affect the brain, that's a risk factor. Low birth weight, if babies that are born with low birth weight, underweight, that's a risk factor. Prematurity is a risk factor. The difference between prematurity and low birth weight, you have full-term baby that's underweight, right? Then you could have a baby born before term. So diabetes in the mother, so pregnant mother with diabetes, a risk factor. Family history of hydrocephalus, also a risk factor. So in older children, what are the signs and symptoms? In older children, usually, I think this is what we want to pick up, and you want to be looking out now here. If you have a baby, like, okay, let me make sure these are not happening. In older children, usually you will have increased intracranial pressure. That will include, they will have headache, they will have nausea and vomiting, they will be changed in their walking. The changes, they will have what we call adduction spasms, that's cranial nerve, They will have slow enlargement of the ventricle. Initially, it will be asymptomatic, so the hair will just start getting big, small, gradually. The older children, because the skull will start getting harder, so it'll be gradual, but yeah, there will be increasing the hair size. In the young children, the babies, the abnormality will be seen usually in the hair size, because the skull is not well developed, so the hair size will change very fast. The cranium will enlarge at the rate of more than the face, so because the hair will be getting bigger, going faster than the face, so that their face will go in, and then the hair get bigger. So they will be irritable. Anyone who them, they will cry, they can't stop, poor hair control, they will get if they're breastfeeding, they will vomit everything, they breastfeed. So they will have bulging frontal nail. We're talking about the one that spoke about open board this morning. So instead of them having a sucking one at that age, which is supposed to be, it would be bulging. And you have frontal bulging. It's different, medical student. There is difference between frontal bulging and frontal nail bulging. So if you have the frontal bulging, that means the front of the face here looking big. Because similar way, there are some people that had a low, not because they have cephalus. And I think young children or you would make fun of people describe their face. I say flat face or what you face. Yeah, so you have frontal bulging, and then you have bulging frontal nail, which is two different things. All of that happens in them. And then you have enlargement and engulfing of the scalp. So if you look on their scalp, you'll see the vein showing shining oil on the face. Then we will also have what we call the McCarran sound. We have sleep nerve pulses, the setting sun sound, like I was talking about the eyes. So the eyes will go in, and the hair will be very good. So they will have active reflexes. They will have irregular respiration. They will have the cranial fissure, the frontal, the posterior will not be as it's supposed to be. So usually, in terms of investigation, like I said, not all the big hairs are right? So we have, normal behaviors. So we see people with big cell with small sound, we still go on investigating. So in terms of imaging, most of the time we scan for MRI at the end. So, of course, MRI, is the best, but you CT scan also give you all the information you need. If you want further information, you put the CT scan with contract will give you all the details, and you don't have to do MRI. So in general, the best, it can be clearly seen on CT scan or MRI. So occasionally other means are used to be able to clinically say, yeah, this is congenital hydrocephalus, so there are measurement clinically we could do to do that. So anatomically for the clinicians or the medical students, we have the bar parietal diameter, we have the temporal horn, we have the frontal horn. So these are important area in measure to be able to determine that the child has hydrocephalus even before getting imaging. So with all of the information I gave in terms of making a decision or suggesting that there is hydrocephalus, if the size of both the temporal horn, I will show you here, if the temporal horn or the frontal horn is more than, if the temporal horn is more than or equal to 2 millimeters in width, then that's suggestive of hydrocephalus. If the temporal horn is more than or equal to 2 millimeters in the ratio of the frontal horn and the intertarsal diameter is more than 0 to 5, that also is suggestive. Yeah. So these are more, I don't want to bog a non-clinician with this. In the medical student, you need to look at this together. So, of course, the sound and symptoms I gave, sometimes all of those things will happen. It will not be clearly just hydrocephalus or congenital hydrocephalus. There are other differential, other things that look exactly like congenital hydrocephalus. So one of them is called hydrocephalus ex vigus. So that you will have enlargement of the ventricle due to loss of cerebral tissue. So the ventricle is large because either there's abnormality in during development, so you don't have a lot of brain tissue. So because of that, the ventricle is empty, just big. There is not excess fluid around it. So we call that cerebral atrophy. Another one I will know more like is a developmental abnormality where the ventricle or the portion of the ventricle will appear enlarged. Right. Of course, people that die who survive and have big heads, but they don't have hydrocephalus. Then there are other developmental abnormalities like agenesis of part of the brain called corpus callosum, and there could be septum uptake dysplasia. Somebody told me, say, I'm worried, I don't want to be here in the evening because you guys will be using a lot of big medical terminology and I don't understand anything. So actually, I'm just calling these words for the medical student, and I'm skipping it faster because I don't want the non-medical people to get discouraged. But yes, these are other things that look like the condition I'm talking about. So there is another condition where maybe the simple way I put it, the child doesn't have the hair, complete empty hair. So that people can say, you get rid, if possible. Somebody can leave home. Just the cranium is there and the ventricle there, like, but nothing, no brain tissue. Or maybe just, oh. So the hair will big and everything. So that one, yeah, just beautiful growth gently, you know. But yes, because that kind of condition also can look like hypertension. So now all the big hairs in double position, right? You get to evaluate the machines actually. So treatment, I'm closing. So there is medical treatment. Yes. So even though the best in the first or the best in the first choice for it is surgery, but we can also give medication that can reduce the production of the CSF. Yes. So that this is such as eliminate, reduce, so that the treatment we can reduce the production of the CSF. Then we can also do spinal tap. We can put injection in the back to be able to draw some of the water from there. But that is also, it's usually done if it is hemorrhage, maybe there was bleeding around the brain. So from the spinal cord, when we do the spinal tap, we'll be able to reduce the pressure. So we do the spinal taps. So surgical management, the goal usually is to optimize neurological function. So if the child will not be able to balance their head and be able to walk, then that's neurological deficit. So the goal of surgery is to be able to make sure that child able to control their hair at the age they're supposed to control their hair. They should sit at the age they're supposed to sit. They should walk at the age they're supposed to walk and be able to go to school, right? So it's not needed to, the ventricle is big, the hair is big, so we're going to operation to reduce the hair. No, that's not what surgery. Yeah. So you can stay even after surgery, the child hair can stay a little bigger than the normal origin. Yeah. So if there's a girl, she can use wig, or she go enough hair to cover up the hair. I think she's normal, she go to school, she fine, her brain out, she got to wear, you can't doctor, she got money. The man, when I see that here. So surgery is not to make a big head to get small. No. So of course it reduces it, but the goal of surgery is to be able to make sure the child have normal neurological function. That makes sense to that. So the surgical outcomes. One, you heard me talking about the program will be on the radio a lot. So you heard me talking about endoscope. So the number one, the best is you can do endoscopic ventricular stomach. So in that you don't have to put shunt. You do the endoscope, especially the obstetric ones to be able to you can use the endoscope to be able to do to open the stenosis. The simple way, the non-medical way I can pull it, especially if there is issue with reabsorption, then you have a port finish. So the medical student will tell you when the CSF is produced in by the current class, in the ventricle, in the lateral ventricle is produced there. There's a pathway it goes, right? Every time we go around asking, tell me the path, where is it produced? What produces it? From this area, where does it go? And you start calling all the different places. I don't want to make you scared with the names. If I come on a medical student now, they will start, from the aqueduct, this, that, cerebral aqueduct, so there is a path, there is a drainage, right? So if there is obstruction in any other drainage, then there is issue. So with the endoscopic ventricular stomach, you actually can be able to solve problems, especially the ones with the obstructive hepatitis. Endoscopic ventricular stomach is the best choice, not division, right? But we don't have endoscope now for that yet. So if we get an endoscope, some of the children will not go with the shunt with the endoscopic ventricular stomach. So shunting, the while will be doing from Monday to Wednesday. So we can do VB shunt. And there are different kind of shunt as well. We can do, so the VB shunt is the ventricular, that means we put in the catheter in the brain, we pass it under the skin and put it in the peritoneum. Not in the stomach, you see the vocal one. So we call it the peritoneum. So it goes there. So we put it in the ventricle, in the brain, we pass it on the skin, bring it to the stomach. That's one. That is called a VB shunt. You can also do the ventricular atrial shunt, right? The cardiothoracic surgeon will be surgery goes to the atrial heart, put it in the ventricle already there. You can also do lumbar shunt. Yes, you can do it from the ventricle or from the lumbar area and then put them on the skin. So you can do peritoneum, you can do lumbar, you can do atria. You can even do there's another one we might do on Monday or Tuesday for one of the babies. You can do submedia shunt. So you put it in the ventricle and then put it on the media. So yeah, different kind of shunting we do. But most of the one we will be doing is the ventricular peritoneal shunt. So Another thing we can do is eliminating the obstruction, right? Talking about, so using the endoscope as well, you can do opening of the stenosis, salient aqueduct. You can, and that, some people think, mobility is high, and success rate is, not as division, so some people don't go for that, but yes, but you can also do, you can open the salient aqueduct that is stenosis as well. So there is another procedure we can do for them. You can do, it's called chorus plexectomy. So we go there and we want to, the current classes, of course, involved in the production of CSF. So these are some of the, so we're doing division a lot. So there are complications. All the good things I said. So most of the babies murdered that will be operated, we have to sit and tell them the good of the surgery, but there are also disadvantages, there are complications. Every surgery have risks and complications constantly involved. So in all the shunt, especially with the shunt, these complications will occur with any of the shunt. There could be obstruction after putting the shunt. There could be obstruction, which is the most common cause of some malformation. So you have bypass the drainage, like this we did a heavy rain. So many of us are living in the flooded area with no water. So you can be like, okay, next time if it rain heavy, I want to make sure I get a drainage that the water will not get flooded in my house. If you open a new drainage, then the rain is passing there, okay, then our drainage get blocked. Of course, the flood will come in here, right? So we put the division that we open a new drainage system. But if there's obstruction, then they will start having symptoms, and they will start having almost the same thing the hair will start to be. So it is very common. So we can tell the parents it's very possible. If you put a division, the child will be getting better, and there will be obstruction, you have to come by. The teacher had a malformation, she came back, and you can stick it up and pause it. Since then, she's been very critical. So there can be disconnection because when we put the catheter in the ventricle, we connect it to the valve, then we connect another catheter to the valve, and then to the peritoneum. So it's possible it could disconnect. So either the one to the peritoneum could disconnect, or the one from the ventricle could disconnect. If it disconnect, then we have to go back to the discussion. So these are complications. Infection. So the father will make an incision to do the surgery. It's very possible. Child that will put down, it could some of that, and they get infected, they develop pus. Definitely, we take it like we get it because we worry if that infection goes to the brain, a different story. So, but infection can occur. Another thing that will happen that could be highway erosion to the skin. Usually, needed patients that are some babies don't have very good skin, so that one thing that we check and make sure the baby's skin is okay, the baby is well nourished, or else because you're passing the shunt on the skin, so the shunt on the skin is not well nourished, it's not okay, or there is other infection that will cause problems. So these are complications. It will be obstruction, disconnection, infection, highway erosion to occur as well. They could have seizure. Even after putting the shunt, they could have epilepsy check. So many of them will put their own anti-seizure medication even after surgery. So it will also ask the father to get a shunt from the ventricle to either the peritoneum or any other place. That tip will act as a pathway or conduit for metastasis. So if there is cancer somewhere else, and you put that tube there, that cancer cell will travel through that tube and go to the brain. Then you can develop brain tumor only because we have the tube, right? So these are all complications. Or they could be allergic to the metal we use. So thank you. Now I'm gonna get the floor for question and answer.
So much, Dr. Bara. Now the floor is open for questions. We are finished, we move.
Thank you, Dr. Bara, for your presentation. In 2020, we said you have 5 cases, 7 in 2021. In 2022, you have 12. What was the outcome of these cases? How many went home and how many did it? My next question here is, being a neurosurgeon, what are some of the challenges you have faced with babies with congenital hydrocephalus? What have been the challenges with the parents and then challenges with the facility? Thank you.
Take that one by one, right?
Yeah.
Yeah, okay. The first question, yes, with that statistic, I think that, I did mention, I'm still kind of searching for further, details of it. And, I was trying to trace most of the chart to see, the follow-up, because the data I got was needed from, the OPD to the operation room, right? So, there are further details need to be provided about how many went home, how many died, or the one that went home, whether they lost follow-up. So I'm working on that article, the state collecting the data, to be able to do a full article. But, most of the cases, from that time, the patients have been discharged in 3 to 4 days. Detail in terms of the number, how many went home and days, I'm still working on that to be able to come up with a full article. Like I said, currently there is no data on the issue of congenital hydrocephalus. Nobody has published any paper. So far, maybe medical students or doctors are looking something, but it's not published, so we can ask this. So we hope that will be a better paper. Yeah, but, as of 2023, up to now, most of them go home. I think mortality so far being less than 1% so far. The next question you said, what are the challenges? Yeah. Challenges is huge. Where parents, many of them, they don't want to come. They don't want, like, they're already discouraged from the community, from the family. Like, you have a Gina, what are you doing about it? So close to 90% of the parents, there's a story that either the parents or community dweller told them to abandon the child. So even some of them to the point of bringing the child to the hospital, they abandon. Currently, we have one of the baby girls. The mother and the father brought the child, maybe to some, the convenience, some kind of way they brought the child, and after like the door of the child was not doing well, everything, they ran away from the hospital. They went, they went to their church, they told the entire church the child died at GFK, the church, they dealt with the baby, they moved, they cried, everything. In a 6 months, they both got a gold number blacklist. Anybody from GFK call, any of that number. As soon as you say, Kevin, from GFK, they put out the one blacklist. So they put all the nurses from our world, the one blacklist, for any doctor I made in the book. In a single area, when they told the church, church people, they big bad to GFK, and they big there. So they have to come to the hospital, they feed him and do everything for him. He did pretty well. So in fight, they named the baby after like a bird. Instead of putting the very last, in their Kevin reality, it's called Kevin food. They didn't want Apple, they didn't want Apple. Yeah, so that one of the challenges, parents want to balance this kind of baby. And I think they're well information about this kind of babies can survive and give people are relevant. I think parents need to hear that. That for example, if somebody from Canada who had this condition and operated on, now they are married, they have children. Even some of the nurses don't believe that babies are likely to survive. They just want to support the parents, love this money, go to see this thing, $150, can't do surgery, sit down in the hospital, sit down 2-3 months, and they will die with all that money. So even the community discourages people. So we have a kind of this. Yeah. So with the hospital, of course, there is this challenge for all of the practices for the new surgeries. So I was talking about, for example, infection. So by right, we should have a separate section for this kind of baby after surgery. We're not going to be mixed with the other babies who have TB in the stomach, brain. Definitely, they will get infection. So the environment is a challenge. We want to do a division now. We can do endoscopy therapy. We don't have endoscope, right? So there are a lot of challenges in terms of equipment and infrastructure, human resources. Not by right, we don't just use any nurse to pick our patient. Even though you are a nurse, you qualify, we have to train neuro nurses. So, but now we have one neuro nurse that is not paid by government or JFK, volunteer, an organization from Canada is won't pay her to be with us. And this will be one. So we have to use the general nurses in JFK to take care of our patients. So many times, master had a coaching test. So I make calls for all the nurses. Don't touch my patient. Don't touch my patient. And they're like, well, yeah, it's huge. So I can work as a nurse, PA, doctor. Yeah. All the other things, is there part of it?
The facility, challenge to the facility.
Okay.
Yeah.
Yeah, I think I answered all your questions, right?
Yeah.
Don't be proud of it.
Yes, something I want to know from your presentation, the courses that you said for hydro to travel. If I'm not making mistake, you said meningitis, health is called accident, trauma to the brain, right? Am I right?
Yes, so
Okay.
as a post hemorrhage.
I'm not yet sure.
Yeah, go ahead.
Okay, looking at those courses, I know that these are courses that cause some mechanical imbalance of the brain. Low lethargic parents can then seizures or epilepsy.
Okay, so just to answer the question, yes. In fact, like I said, that's one of the complications. So apart from all of the symptoms I listed, some of the children, that's exactly what we'll be presenting with. Seizure. You have seizure. So even after surgery, like I said, one of the complications, some of them will still be having seizure. So we have to put them on anti-seizure medication. Yeah. And you're talking about the causes. Yes, I said infection, and I was specific to mention meningitis because that's infection to the brain. So it's not just infection in the West, central nervous system infection, right? So yes. Also post-hemorrhage, post-traumatic hemorrhage. So that way you can avoid adults. So if you're an older person, you have an accident, a trauma to the head, and you have bleeding around the brain, yes, you are at risk of having it. That's acquired, right?
But we have a situation where the computer is going on fast. There's a possibility that they will have identified someone annoying. Okay, what are some of these mechanisms that are being put in place in order to prevent some of that because that happens to me?
Yes, so the OBGYN many times That was the encourage pregnant women to go for antenatal care, to go to the hospital regularly when you're pregnant. In fact, I use the word, I'm sorry, I usually say in the real word. I run out of real word. Yeah, but in a setting where everything is, it can be detected with pregnancy. But most of the cases we have in Nigeria is after the child. Sometimes, there's complications during delivery, and they do CS. Oh yeah. But it's not supposed to be like that. So if you have a good, regular antenatal visit in where equipped facility, they should do ultrasound for the pregnant women. 12 weeks, start following our baby. In fact, in the normal setting, they do all the genetic profile to know whether that baby had any genetic abnormality. So when I was in China, my second son was conceived in China to the hospital. So at 12 weeks, in fact, we gotta know everything beginning from 8 weeks, 12 weeks, up to 18 weeks, 20 weeks, 24 weeks. All the tests, genetic abnormality, whether you have any problem or not, everything will check. So in the real setting, I think the doctor say you can be able to detect if there is neurology defect or if there is congenital hepatitis to be detected during pregnancy. And so in the places where they get an option, they give the parent the option. Do you want to have a child? Do you want to terminate the child? The child will have this complication. So if you still want to have a child, but know this, you want the child with complication. You want to terminate the child, we can terminate the child. The other thing on top of it, right? And there is even still an option in the advanced setting where they can do some intervention, So in the best setting, it can be diagnosed during pregnancy, and clinical decision that will be made during pregnancy.
Thank you, Dr. Malam, and it's good. I have a question, and then I would like to project. My question is, can the child acquire, how does he find it, why the mother is pregnant this summer? 1, 2, I will project for your education that every one of us are here, can carry the message in our community. I'm having a experience just last night here. I had it in, I think my skin was breathing. I have a neighbor, a young boy. He has a child. When he said the child too weak, too soft. So I always have to say, everybody should be soft. And there's some full hard, some full soft, some full weak. Weight, lazy, some full strong. Just grab the boy, jump in the board. Yeah, I said, what happened when you for the child brain? Every day I will talk to the child when 4 years now October. Every day I will talk. Every day, man, I want to show you a video. Not just you, Mama. Yeah, when I have to get the ball, put in the ball. I said, wow, yes. So we need to have our one neighbor and people that we know so they can take care of that young baby. That right now, from 2008, we have 4 of these babies that were born and changed in the hospital. 2 died, about 2 and I couldn't take care of them very hard. The 2 are there, nobody know where their parents when they just born and died. How are they? You got me? Wow, the other one, 5 or 6 years, the youngest. They were just they want to start having this children. The other one is 4. Since 2004, they carry them when you're almost like 4 or 5 years. Just now, even to turn around and go with. So I thank you for the knowledge.
Okay, the first question is a child can acquire congenital or every child can acquire hydrocephalus because that will be congenital anymore, that's acquired, right? So the congenital one is not because infection or trauma or the other things that happened. It was, developmental abnormality. So that's congenital. So acquired, that means the child was born and other things cause it, right? So Yes, so even in the hospital, if during delivery, the midwives and the healthcare provider, they're not careful and they not, of course, will not, yes, there could be, hemorrhage. Yes, so yes, to answer that question, child can acquire, hydrocephalus due to, from, which will be, hemorrhage, post hemorrhage. And then, yes, I agree with you. In the lot we need to do, now we ask the question about the challenges, with the parents, with the hospital, with the, so the challenges we. So I even believe we even have our equip center right now to deal with that situation where I just saw 50% of the problem. We still have to deal with the issue whether parents or the community get information on where to bring this kind of thing. Yes. Yeah. I tell you, even providers who don't have the information well with their, maybe in a clinic, a mother gave birth to that kind of child, hey, just forget about it when in Nigeria, and I'm not being not to be done. And a nurse, a midwife, PA tech, a parent alive in the hospital, and you know that person is more inclined medically than them. What they do. It's just the child, the child, let's say, you can't do nothing about it. But if they're all informed, like, yeah, you can have this condition, and something can be done, child can survive. I say 3, 4, 5 nurses, I mean, with experience, I've been working, they asked, how did you really want to do? Yeah, you can survive. You say, I think, the one you are one and the hospital, dying. Of course, if nothing is done, many of them will see their first birthday. If nothing is done, many of them will see their first birthday. Some of them with complications go up to 3 years, 5 years. Yeah. But if intervention is done early, everything is done well, you can go into a full adult and have a normal function and be functional in society.
Okay. Dr. Bala, thank you for the session, but I just want to find out something because in our setting today, for all we are not young people, we're here today to learn. And what I want to know, what can really be the cause of the child staying too long on the ground?
Okay, so to answer that question, I'll answer in the scope of our work today. So plenty, of course, when you enter hydrocephalus, if it's not treated, if there's no intervention, could just be one, which is 0.0001% of the many causes. Yeah, and all the other causes right now, I will have to open a whole medical, a lot of medical and non-medical things. Even malnutrition, if you're not feeding the child food, if you, and the child just 1 week old, you start stalking them with high rates and taking different and giving them plenty of other things. Child will become malnourished. Like, my wife is a very, very good mother. She breastfed all her babies up to, we said minimum 6 months, right? Yeah, straight, only breast milk up to 6 months. No water, no nothing. Everybody should feel. You see it, you like doing it. And so my kids are very, very smart. Yeah, and there is so much to do with that, right? Even parental care, especially maternal care, they have a lot to do, right? So there are a lot of things, right? I just gave you a taste of small. All right, so thank you.
Thank you, Dr. Bala, and the previous presenters. My concern is about whether there will come a time where you will not get frustrated. Start thinking about going out to look for greener pasture because you are plus the other guy who spoke before you. You have acquired education, is what I have and everything. But you're not being capacitated to do your work. So what are you doing to make you and your coding functional the way you should be? Because it's all about the equipment, and there are very frustrating and all of this. And additional staff to help you do your work, qualified nurses, specialized nurses, maybe additional people like you to send for training and come back to add to you. What are you doing in that regard to push your case in the case of your department?
Thank you for that question, but this is just one of them I'm doing. But don't say one day you get frustrated because frustration thing that was. So I'll prepare for it. So when I'm coming back to Nigeria, the room always say this. I had an option to be a research assistant, to stay, teach and do everything. I'm like, no, that's what I want to go about. And just get my family over to China and, or maybe somewhere else in Hong Kong, and where to go, right? But, one, not because I got not Nigeria. Many people, they commitment got not Nigeria and go. So, but I had commitment to my country and up there. I want to set a right precedent for my children, country. I said to the government, like, I will come back no matter what. And so that's why I came back. Not because everything was so, rosy. My boss started doing a prayer. So I know he really wanted to attend my graduation though. But he flew to China, like, over. And I don't want to die, let me please get a cop, If we die, then we'll all die together, right? He was afraid I was not going to come back. So he came to the graduation and did everything. I said, okay, if I were you here, I'm going. Not because you came, but I'm going. And I didn't come with high expectation because I tell people high expectation, satisfaction. Low expectation, high satisfaction. If you going to beg somebody, for example, and your expectation is to get $1,000, $1,000 to the person, very sure that the minimum you get for that 1,000, and you came, you ask the person, or maybe that's like about that's a new discussion. Like, you think it's less than 1,000, and then you came and gave you $20. You will get so frustrated because the expectation was too high. But let's say you're coming like, if that will give me $20, at least I can, buy for a job, that I can make something. And I give you 1,000. You will be almost satisfied. So I think coming this kind of setting to work, that was my own intercultural strategy I used because I lived out of Liberia for 10 years already. So I came from Liberia, another culture, lately the Asian culture. I got a lot of cultural shock. Then I got adjusted. I became like a Chinese person. Then coming back, I have to readjust, right? Many times I have to press, after you see the camera, I will press. 3, 4, 5, and 11, I remember I need to take a look on the okay? Then my wife will laugh at me. Many times I'll be like, oh, let me get it, yeah. I'll be doing something to get it. So I have to get adjusted all over with a lot of things, right? So like re-enter shock, right? So I didn't come with high expectations. I think that was a strategy to help me. But of course, the first day I got frustrated. The frustration I really did. But I said to myself, it's not just about serving self and with that honest heart, I think what you guys, right? So why should I just have a medical conference and why should I be having a fundraiser to want to buy equipment to be used? Ministry of Health, I should say that government responsibility, the Ministry of Health should do it, but not like we should do it. But we will be here tomorrow asking about what am I doing? We'll be here tomorrow telling people that, hey, if you don't put your $100, if you don't buy a CN, it could be your brother or it could be you who could have a spinal cord injury or motorbike could hit you or a car could hit you or you could fall or somebody on the farm could fall and the person will have to finish here. If you don't have a CN, we can't do nothing for them. We just look at it, look at it. They say, go down. And at that time, now you want to perform the record, we can't. Many times the challenge is when it's not us, then we think it's not. But we can do our little step and tell us, right? When I came by 2022 for the mission, for the neurosurgical mission, there was huge money. My wife said, don't back me to get a family. That was some money. Just finish and come. Yeah. So, I said, somebody blessed me to come home to see you before, COVID was challenging to, I'm gonna come. So she's like, send the money, we are dealing, let me complete the house, tell the person, say, you see the money for the ticket. I said, no. The person say I should buy a ticket to come and see my family and come. So I bought a ticket and came. Now, part of the mission actually, her best friend from high school had an accident. Well, we are JFK, she had a spinal cord injury, she needed surgery. We're all very busy, and they brought her to JFK for 14 military hospital. I mean, very close, that was like, close to us. And she was like, they were waiting for a neurosurgeon to see her, that the door was busy out there. She didn't even know our in time. And then she's there. Then she called her. How's my brother-in-law? Can you call him in China if you know anything from JFK to come? Say, but the brother-in-law here. You remember me say, I'm in JFK analyst. And so because of my presence and my influence, we were closing. The mission was ended up Friday. And when I went and saw her and went and presented her case to the consultant I was there, well, we have three other patients, but they're not emergency. With your relationship with this guy will operate. So she always say, look, you came like you got the same thing, right? And during our same mission, there was when she was pregnant for our first son out of the country, unless you have a clinic that took care of her, she had complications, the woman didn't sleep. She didn't go home throughout the night. Her grandson had a brain tumor and had a hydrocephalus needed to be operated at home. And so the house started with peace clinic, no one go away, she called her. Can you call my son-in-law? Say, well, your son-in-law here. Yeah, I want to see the debate with the division for the ball, doing great. He had chance now, so they can build a better credit for sorry. So by buying up putting together come too close to me. So I feel like it's not sometimes, doing everything, but you say 1, 2, 3, and sit down very, very close. So that's why I feel the little I'm doing, it means a lot to that 1 or 2 patient. And let's just take, for example, teacher. If, my entire profession as a neurosurgeon is just having teacher, having the opportunity that I already had the teacher, she can grow and become somebody like Viva. It's just an idea, have a life, I feel that I achieved. So I'm not going to give up.
So much, Dr. Bala. Now we will take announcement.
One very important announcement. Let's take a group picture before we disperse. So you should that in our conference, we want to get a group picture. And all of our participants, when you sign up this morning, you're part of the conference. So we want to do a group picture. So we probably want to do it with our banner. We don't want out there just to be a picture. So we can have a record. Yeah, so we go outside there at the front where the scanning banner is in the picture. So a group picture there before we leave. Secondly, all our participants, when you came, we're going to give you certificate of participation. You can show that you attended a medical conference. Yes. So it's not just the knowledge you had aspects that you wouldn't have the opportunity to just see in the work. And some of the medical experts you saw here, they came here, I can say, the relationship. So they have many other sketches, you saw that Super would join you online, she did everything just by us, she kind of stay beyond the complete relationship, right? She could be in the same. So if there's any other meeting, we'll screen her saying her card is wrong. So some of the things you heard here, things you can find in others, right? Somebody was talking to me, asking some questions, and I say, okay. I said, yeah, went to the other place, you can pay someone $50 to see the doctor. I said, I've seen this one. If you say you want to see me there, to ask me the question, get asked me now, and you're going to get $5 for them to come into it. And that's true. So don't take it lightly, the information you got here, the things here. will get a certificate for that for coming to the conference. So not just those who sign up, those who attend it. So that's why we took attendance to here you get certificate. But we want to encourage you to come tomorrow because we'll get tomorrow. Because we'll get you come as well. Yeah. So that's the second announcement. And thirdly, we want to say if you are a medical person, whether a nurse, a pharmacist, a doctor, a medical student, and you're a Christian, the two requirements. So Icmfel, the International Christian Medical Fellowship, have full membership. Full membership is for those who are Christian and they are health practitioners. Anything they are health practitioners. Pharmacist, doctor, medical student, nurse, and if you're a Christian, you're interested in what we're doing, you can sign up in membership. So the attendance that lead us on that, so you can sign up. Go to our website, www.icmfel.org. The membership form is there, fill it up, but if you do it here as well, just start that. So we'll be updating our membership today, care conference, and then we'll be part of our different group and everything. So, full conference, we don't know, could be in Liberia, could be in Ghana, could be in Canada, it could be anywhere. Right? Naomi is a Liberian, but she's John was in Jamaica. Right? But student, our administrator is from Ghana. I'm from Liberia, I'm a visionary group, but it's not a Liberian thing, it's international. So if you are a health practitioner, you want to be a full member, medical student, they join us. You get a full membership. If you are not a health practitioner, but you are a Christian and you're excited about what we're doing, you can also be an associate member, you can join. That means they access to our information, to things to do and everything. So you just mark it for a on the scene, I think listen for you put member or you put associate member, then we start sending you email and you get the authorization to update you and all of that. So we want you to do that and we hope together we can make a change in our life.
So, we're going to take closing prayer. We started with prayer, so we will end with prayer. Let us start. Father, in the name of Jesus, we thank you for this beautiful day. We thank you, oh God, for every word that came forth, and we thank you, Lord, for the positive impact. Father, as we are living and are living your presence, for your presence will continually abide with us now and forevermore, in Jesus' mighty name. So we can go out now for this photo.
Yeah.
Thank you so much, all of you. It was amazing. I'm very impressed with the turnout. Thank you for coming to the conference. Icmfel decided to have you in our conference. Let's just go to the front, Pastor, or